Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Genentech.
Well, hello, everybody, and thank you for taking time out of your day to talk about colorectal cancer and the neoadjuvant and adjuvant treatment. This program is titled The Practical Community Colorectal Cancer Clinic, Aligning Biomarker Analysis to Treatment Selection. My name is Chris Liu. I'm a GI medical oncologist at the University of Colorado Cancer Center, and I'm going to let Miriam introduce herself as well.
Hello, everyone. My name is Miriam Schlabi. I'm a medical oncologist at the Netherlands Cancer Institute in Amsterdam, the Netherlands, and it's great to be here.
Thank you so much for joining us, Miriam. And over the next 30 minutes, we're going to talk about the treatment of stage 3 and in some cases, high-risk stage 2 colon cancer. And it's really remarkable when you think about the last 2 decades of the treatment of colorectal cancer. And when you look at the adjuvant treatment and even some of the neoadjuvant treatment, there really has been no change in the drugs that we use. And so we've been using, FOLFOX chemotherapy and CAPOX chemotherapy for many years. And it's exciting, right, to finally have some data to show in a specific group of patients with deficient mismatch repair or MSI high colon cancers, where we can finally offer something that will truly improve our patients' disease-free survival and obviously what we're hoping is overall survival as well as their quality of life. And so in this program, we're going to talk about a couple of clinical cases and we're going to ask our audience here to think about what they would do in these specific patient scenarios. So we're going to speak directly about adjuvant therapy, talking about the ATOMIC study. And I got to tell you, we're very, very fortunate to have Miriam here with us, who has really just changed the field in the neoadjuvant space. And she's going to be talking about the NICHE 2 study. But we're going to start out with a case. And so this is a patient with stage 3 colon cancer. So this is a 51-year-old male who presents with hematochezia. And the colonoscopy reveals a fungating mass in the sigmoid colon, and biopsy confirms moderately differentiated adenocarcinoma. Testing is performed on the biopsy specimen, shows loss of MLH1 and PMS2, and so this patient does have deficient mismatch repair stage 3 colon cancer, and luckily staging studies reveal no evidence of metastatic disease. So the patient is seen by surgical oncology, goes immediately to surgical resection, and a T3N1 tumor is found. And so there's only 1 out of 16 lymph nodes that were positive, no tumor deposits. And again, NGS is actually performed on this tumor specimen, and the patient's tumor is found to be MSI high. So the patient comes to the medical oncology clinic for further evaluation and management. And what we would love everybody to think about is, okay, well, this is a very standard practice where patients are oftentimes seen by surgery first. They get a surgical resection. You have stage 3 disease, in this case, low risk stage 3. So the question is, well, what would you recommend in this instance? And so your options are here: observation with serial ctDNA testing. ctDNA testing in this space is a talk in and of itself. The standard has always been, 3 months of FOLFOX or CAPOX. Or would you now consider 3 months of FOLFOX with a atezolizumab for 1 year, or do a full 6 months of FOLFOX with a atezolizumab for 1 year? So these are your options. We're actually going to come back to the case in the middle of our talk after we have a chance to talk about the data in the adjuvant setting. Now, historically, with deficient mismatch repair or MSI high colon cancer, this is really historically how we've thought about the disease, right? So a little bit of a higher prevalence in earlier stages, so stage 2, around 50 to 20%. And historically, we've always said that the prognosis of our patients with MSI high or deficient mismatch repair colon cancer in the stage 2 setting is just outstanding. It's really excellent. I'm going to show you some additional data here in just a bit. With stage 3, we know that the prevalence is a little bit less, around 10%. The prognosis considered to be a little bit better of N1, same of N2. Again, I'm going to show you some data on that. And then with stage 4, we believe that these hypermutated cancers are too deranged to metastasize. So this really only represents about 4 to 5% of our patient population. But of course, once that metastatic clone has been selected, we actually think that the prognosis may be same. It may actually be worse. When you look at some of the stage 4 studies with immunotherapy and chemotherapy, the response rates with chemotherapy has historically been lower than what we would expect. So this is a pretty different biology, particularly in the stage 4 setting. Now, we're very fortunate. This is a very difficult patient population to study because, again, it's not a majority of our patients, but this is data from Miriam's group, which is really, really helpful to better refine how we think about the prognosis of our patients with deficient mismatch repair colon cancer. And so what you see on these graphs is overall survival for stage 2 colon cancer and overall survival for stage 3 colon cancer divided up between microsatellite stable or proficient mismatch repair and MSI high or deficient mismatch repair. And so proficient mismatch repair is in the blue lines. The yellow/gold lines are deficient mismatch repair. And this really starts to question this idea that we had that stage 2 MSI high colon cancers just do outstandingly well. And so you can see here in overall survival in stage 2 and in stage 3 is somewhat similar. Interestingly, when you look at the stage 3 data, there's actually this initial dip in overall survival for the deficient mismatch repair. So the stage 2s may actually not do quite as well as we think, and the stage 3s certainly, at least early on, it looks like there's a little bit of a separation of those curves, but that's not statistically significant. And I really want to highlight this, and again, this is great data from Miriam's group showing 5-year overall survival for T4 disease. And what I really will point to here is that the yellow/gold lines, which is the deficient mismatch repair, are actually showing worse prognosis with T4 disease. And it really speaks to what we're going to talk about later in this program, and that is T4 disease in and of itself is a very high risk factor. And it's one of the things that we really want to keep an eye out in terms of offering the best therapy, whether it's in the neoadjuvant setting or the adjuvant setting. So really appreciative of this data because these are pretty big cohorts when looking at deficient mismatch repair, and these are hard populations to study. One question that has always come up in clinical practice is that do our patients with MSI high colon cancers benefit from the addition of oxaliplatin to fluoropyrimidine therapy? And the answer here is yes. The red lines that you see here are microsatellite stable cancers with 5FU, and then you see what the improvement is with oxaliplatin. With MSI high, you can see, again, some improvement with oxaliplatin. So we have always thought that adding oxaliplatin to this patient population is helpful. So that really brings us to our case at hand, right? We had a stage 3 colon cancer. The patient has already had his cancer resected. So what does the data say in regards to adding immunotherapy in this setting? So the ATOMIC study set out to answer this question in the MSI high population. So these are patients with fully resected stage 3 colon cancer. They were deficient mismatch repair or MSI high. They had no prior therapy, and these patients were stratified by T stage, N stage, and where the tumor arose from. And it's a very simple design, randomized 1-to-1 fashion between FOLFOX chemotherapy for 6 months, which is the standard of care at the time, or 6 months of FOLFOX and atezolizumab, followed by an additional 6 months of atezolizumab monotherapy. When you look at the patient population, I do want to highlight that this did include about a third of the patients that had what we would consider to be high-risk stage 3 disease. So about a third of these patients had T4 disease, and about a third of these patients had N2 disease. So it did include a more aggressive histology population, which is great because that obviously reflects our clinical practice. And when you look at the primary endpoint of disease-free survival, you see that there's a 10% disease-free survival difference between those patients receiving FOLFOX alone and those patients receiving FOLFOX and atezolizumab. And this really confirms that the addition of atezolizumab in this patient population does improve disease-free survival. When you look at the disease-free survival subgroups, you just want to make sure that the treatment arm that includes atezolizumab had broad efficacy across, lower risk stage 3 and higher risk stage 3 disease. And certainly we see that, right, with hazard ratios favoring FOLFOX atezolizumab, even in T4 disease, even in N2 disease as well. So the question is, when we add a year of atezolizumab, what does that look like in terms of adverse events? And the adverse event rate here is fairly similar. I will note that there's a little bit of a higher grade 3 or 4 treatment-related adverse event rate in the FOLFOX and the atezolizumab arm. Luckily, there were very few deaths on this study in quite a large population. When you look at the adverse events by treatment arm, you can see here that, again, it's relatively similar. I will note that there's a slightly higher increased rate of neutropenia. There's also a slightly higher rate of diarrhea in the FOLFOX and atezolizumab arm. When you look at the toxicity by treatment regimen, there's some immune-related adverse events that we would expect to see with the addition of atezolizumab. And so you can see here that there are higher rates of hypothyroidism and hyperglycemia. There is a slightly higher rate of grade 1 and 2 and grade 3 and 4 diarrhea. And we imagine that that may be related, certainly some partially responsible to chemotherapy, but with atezolizumab, you can have some amount of colitis that causes the diarrhea as well. And as would be expected, you see a little bit of a higher rate of rash with atezolizumab as well. So the key takeaway points from this data, from the atomic data, is that, when we think about historically how we treat patients with stage 3 colon cancers, for 2 decades, the answer has been FOLFOX or CAPOX. But we know now from the atomic study that adding atezolizumab to FOLFOX does significantly improve disease-free survival for dMMR MSI high stage 3 colon cancers. And Miriam's going to talk a lot more about what the data is in the neoadjuvant setting. When you look at the NCCN guidelines, and these were just recently updated, I think around 1 or 2 months ago, but atomic results have been incorporated into the NCCN guidelines. And so those patients with deficient mismatch repair and that ultra hypermutated phenotype, FOLFOX atezolizumab shows up here. It's interesting. CAPOX was not looked at in the atomic study, but that does show up on the NCCN guidelines. But obviously, if patients are not eligible for immunotherapy, then you can use CAPOX and FOLFOX as well. And I do think that it's interesting that in the NCCN guidelines, you do see T4B disease, and that consideration there for considering chemotherapy with atezolizumab does exist as a 2B recommendation in the NCCN guidelines as well. So I'm going to stop there and actually going to go back to our case. I'm going to ask Miriam for her opinion. So for a 51-year-old gentleman with low risk stage 3 resected colon cancer, of all the options, what would you do in your typical practice?
Well, thanks, Chris, for putting this so nicely and showing all the data. I think considering all the data that we have, and in this situation for this patient, I would, if it was available, because we don't have that in the Netherlands, but if it were available, then I would give that patient the opportunity to receive atezolizumab in the adjuvant setting with chemotherapy, of course. Although I would be very hesitant to give 6 months of chemo. So if I have to do it with chemotherapy, then that would be 3 months. So I would go for that option. I'm not sure about the CAPOX. CAPOX would be an option, of course, even though we don't have the data. But well, with the atezolizumab 2 weekly dose, that becomes a bit more complicated, I guess. But either way, FOLFOX or CAPOX with atezo for 3 months. What would you do?
Yeah, I think it's we're always taught to follow exactly what the clinical trial did, right? And so when you think about the way Atomic was set up, it was 6 months of FOLFOX. And I really chose this case specifically because of the N1 disease. We would consider this to be low risk. And I think in actual practice, I do feel very comfortable with giving just the 3 months of chemotherapy. Again, there isn't necessarily data in this specific situation to tell us that 3 months is okay, but I think that we can safely extrapolate. And I would give 3 months of FOLFOX chemotherapy, get the full year of atezolizumab in this setting.
Sounds good. I think we agree on that.
All right, so I'll turn it over to you to talk about a case in neoadjuvant setting.
Thank you. So yes, our next case is a 68-year-old female with a history of mild hypertension who presents to the GP with fatigue, iron deficiency anemia, and no other symptoms at that time. On colonoscopy, a mass is found that's semi-circumferential of approximately 5 centimeters in the ascending colon. She doesn't have obstructive symptoms. That's an important thing to say here. And on biopsy, it's an adenocarcinoma, poorly differentiated with loss of MLH1 and PMS2 expression, so an MMR deficient tumor with hypermethylation of the MLH1 promoter. So this was not a Lynch-associated tumor, but an MLH1 hypermethylated tumor. On CT scan, this turns out to be a very bulky tumor. It was only 5 centimeters on endoscopy, but it was very bulky with a CT4B status, with invasion of the abdominal wall and also of the adjacent ileum. And this patient had very enlarged local regional lymph nodes, possibly tumor deposits, but the radiologist could not discern that. And the largest diameter was actually 2.1 centimeters, so that's quite big. And there were no signs of distant metastases. So based on this case and the data I just showed you, what would you recommend treating this patient with? Would you go for direct surgery and then opt for adjuvant treatment, maybe with the atomic study regimen, dependent on pathologic assessments and whether you see that the lymph nodes were positive? Would you go for neoadjuvant FOLFOX chemotherapy? Which is, well, neoadjuvant chemotherapy is not standard, but here we have a T4B tumor, of course. You may want to consider doing something in the neoadjuvant setting, or would that be the nivolumab plus ipilimumab, just 4 weeks of treatment according to the NICHE-2 regimen, or would you go with neoadjuvant dostarlimab for 6 months of treatment? And I'll come back to this case as well at the end of the presentation. So let's talk about neoadjuvant immunotherapy and why do we think neoadjuvant immunotherapy is generally a better option than adjuvant, even if you consider just immunotherapy alone without chemo. So what we've seen over the years, and especially at the dawn of immunotherapy and neoadjuvant immunotherapy in general, and this is data from melanoma studies, showing that if you give neoadjuvant immunotherapy, the effect is much better. So we see a more clonal, a more diverse T-cell repertoire that is induced when you give neoadjuvant compared to adjuvant immunotherapy. And this is probably because you still have the tumor in situ. There's the antigens of the tumor that are in situ, but you also still have the T cells that are invading the tumor and the lymph nodes as well. And this is probably helping to engage more T cells, more antigens, ultimately leading to a better response. This is based on translational data, but ultimately we also have clinical data from melanoma again. And this has been the best example to date, together with the SWOG 1801 study in melanoma. And this is the NADINA study, where patients with advanced melanoma were treated with either neoadjuvant immunotherapy with nivolumab, ipilimumab, just 2 cycles, or they received adjuvant immunotherapy for a full year with nivolumab. And what we see here is the difference in event-free survival for the patients receiving either neoadjuvant or adjuvant treatment. And there's a big difference in the adjuvant and neoadjuvant treatment. So either a year or just 2 weeks, 2 cycles of treatment. And the blue line corresponds to the patients who received neoadjuvant treatment. Over 60% of these patients had a major pathologic response, so near complete or complete response. And these patients did not receive any additional adjuvant treatments after surgery. But still, those patients did significantly better in terms of EFS compared to the patients who received a full year of adjuvant immunotherapy. And I think this is one of the best examples of how neoadjuvant compared to adjuvant immunotherapy works. Then we have, for colorectal cancer and colon cancer specifically, the NICHE-2 study. And what we did in the NICHE-2 study is based actually on data from melanoma that were generated back then. And we were seeing very good responses in melanoma patients. And after that, a lot of other tumor types followed, including colon cancer. And we designed the NICHE-2 study, where we treated patients with nivolumab, ipilimumab at the first cycle, then a second cycle of nivolumab, and then patients underwent surgery. So it was just a 4-week treatment, and this is a 2-weekly treatment that you give, and then the surgery was planned within 6 weeks of that start of immunotherapy. We try to include patients with high-risk disease mostly. So we know that radiology or radiographic staging is not great for colon cancer, but we try to include only patients with at least T3 tumors based on clinical staging and or lymph node positive disease. Patients had to have had previously untreated MMR deficient colon cancer and no signs of radiologic perforation or clinical signs of obstruction. So we included 115 patients in the full population, and what we saw is that over 65% of patients had clinical T4 tumors. Again, this is based on radiographic staging, clinical staging, and I'll come back to that comparison with chemotherapy also in a minute on how this compares when you give neoadjuvant chemo versus immunotherapy. But this is a population, pretty much real world population, with the oldest patient that was included here being 82 years old and the median age of 60 years old. Most patients, a bit over 50% were female, so 58%. And based on the clinical staging, the radiological staging, 67% of patients had lymph node positive disease. So, and this is what we saw and this is 111 patients in the efficacy population. And what we saw by just treating these patients with 4 weeks of neoadjuvant immunotherapy, 98% of patients had a pathological response. 95% of them had a near complete or complete pathological response. 68% of those patients had a pathological complete response. And this was all within 5.4 weeks median duration from start of immunotherapy to treatment. And this is a very quick and very deep response in this patient population with mostly locally advanced disease. Then, of course, the question is, does this translate into long-term outcomes for these patients? And well, yes, it does. What we saw is that patients who were treated on this trial, none of them had recurrence of their disease. With a median follow-up of 3 years that we presented at ESMO, the 3-year disease-free survival was 100%. And this is, of course, ultimately what we want to see for our patients. It's not just about the short-term effect, but also the long-term effects. And overall survival data are coming very soon. So, as I mentioned before, I would come back to how this compares to chemotherapy. And what we did is we collaborated with the Foxtrot team. And the Foxtrot study was the first actually to test neoadjuvant chemotherapy in colon cancer patients. And of course, colon cancer, the neoadjuvant regimens have not been very commonplace. And now we may be moving a bit more towards that, also in MMR proficient colon cancers. But in Foxtrot, patients with both MMR deficient and proficient tumors were included because back then we didn't know that these patients should be treated with immunotherapy and not with chemotherapy. So what we did is we compared patients from Foxtrot with MMR deficient tumors and the patients from niche 2, of course. And we selected only patients from niche 2 who would have been eligible for the Foxtrot study. And in Foxtrot, patients were selected based on having at least T3 disease, clinical T3 disease, based on radiographic staging. So, and this is the disease-free survival curves that are from the 2 trials. So in the blue line, you see the patients from niche with a 100% 3-year disease-free survival. And from Foxtrot, if you take all of those patients together, the disease-free survival at 3 years is 80%. But then if you consider the patients with clinical T4 tumors, that was 70%. And again, this is not based on pathological staging. This is based on the clinical staging. So clinical T4 tumors convey a bad prognosis, regardless of what the pathological staging would have been or is ultimately. And it's important to note that we also saw that in terms of the pathologic responses, if you give neoadjuvant chemotherapy, which is until recently the standard of care, and I think we're shifting for the adjuvant setting at least to giving chemo plus atezo, but this was the standard of care with FOLFOX chemotherapy, and giving them 3 cycles of neoadjuvant FOLFOX led to pathologic responses in 7% of patients. Giving neoadjuvant immunotherapy for 4 weeks, 98%. So the niche 2 hasn't been the only study to study neoadjuvant immunotherapy in MMR deficient colon cancers, and I think that's a very good thing that a lot of other studies using different regimens, different combinations, or monotherapy of immunotherapy have shown that neoadjuvant immunotherapy works exceptionally well for patients with MMR deficient tumors, with very high PCR rates across all of these studies, with just IO alone, without chemotherapy. And what is also important to note is that if we look at the grade 3 to 4 adverse event rate, that is not, well, this is actually, I think, very acceptable when you compare that to chemotherapy and what we see in terms of adverse events with chemotherapy alone or with the combination with immunotherapy. So I think based on this, that treatment can be shown to be very efficacious and also very well tolerable. And of course, patients do have side effects because we do that with all of the treatments that we give patients. And this is immune related for immunotherapy. But in general, this is a very acceptable toxicity rate for this treatment. And that brings me to the key takeaways from neoadjuvant immunotherapy, is that neoadjuvant chemotherapy is largely ineffective in patients with dMMR colon cancer. In the adjuvant setting, Chris also showed that adding oxaliplatin does convey a benefit for patients with MMR deficient tumors. But when we consider in the neoadjuvant setting, at least looking at the pathologic responses, that is very minimal what we see there. We also see that neoadjuvant immunotherapy is highly effective and conveys a remarkable disease-free survival. Even though we don't have a comparator arm in niche 2, I think we would expect about 20 to 40% of patients that were treated in niche 2 to have had a recurrence, and this was not the case. And lastly, I would say that neoadjuvant immunotherapy should definitely be considered part of the standard of care for patients with dMMR colon cancer. And that brings me back to my case that I just presented. And maybe before telling you what you probably know what I would answer, I would love to hear what Chris thinks and what he would do.
Yeah, I appreciate that outstanding overview, Miriam. And I think whenever you see these results, right, certainly in the adjuvant setting, it's great. And in the neoadjuvant setting, it's really wild to see a 100% disease-free survival curve, right? I wasn't sure I was ever going to see that over the course of my career. But, for this patient, I actually saw essentially this patient in our multidisciplinary clinic yesterday. And exactly with that T4B kind of estimation, and I know we can talk about radiographic staging, and that's not always the easiest thing. But for us, it was very clear, right? It's a very bulky tumor, and I think here, certainly while the patient could immediately go to surgical resection, we wanted to give that patient exactly the niche regimen, the nivolumab and ipilimumab, and then another dose of nivolumab, and then take the patient to surgery. We've had a lot of experience in the neoadjuvant setting for these kind of higher risk stage 3 tumors, and I'm happy to report that the path responses that we're seeing have been really extraordinary. And of course, at that point, when the patient undergoes surgical resection, that's pretty much it. Miriam, your experience with this.
Yeah, so we can only treat patients on clinical trials. So this has been all patients on clinical trials that we've given neoadjuvant immunotherapy. And we've had follow-ups on niche 2 with other regimens. And, we keep seeing these fantastic responses for these patients. And it's mind-boggling every time that we see patients come back into our clinic after neoadjuvant immunotherapy, that virtually all patients respond. And I'm happy to hear that also in the real world setting, you're seeing the same thing, right? Because that's ultimately what it's all about. And what we want to see is that this is not just a clinical trial population, but it's also representative of the overall population that we see. And I actually chose a case that was quite clear in terms of radiological staging. So, T4B tumor, you had an N2 stage, or at least very bulky lymph nodes. So that makes it a bit easier to decide on what to do, I think, because you want that R0 resection. You don't want the risk of having an R1 resection. But yeah, so I think in some other cases that might be a bit more difficult to decide on. What do you
Absolutely.
think?
Well, I think we're out of time here. I appreciate everybody's attention, and Miriam, just sincere appreciation for all this data, but also for your wonderful presentation as well.
Thank you so much for inviting me, for having me
Thank you,
here.
everybody. Appreciate it.